Why do you think that oncology groups or systems would benefit from adapting the patient-centered medical home system as opposed to an ACO?
In most cases, the cancer care oncology does not fit into an ACO model because it's too unpredictable. The ACO model rewards savings at the end. And in our world, when you've got very effective drugs that are coming out, but they're very expensive drugs as well to help with cancer care, that works in the opposite direction of what an ACO model may want to do. So very few ACO models want to embrace a cancer center due to those very reasons. It's counterproductive to their goal of trying to save money towards the end. So I think the impetus then is for the practice in the oncology center to say, okay, what can we do to create value for that ACO model and or value for different ACOs in the same market. Therefore, what can we do to maximize the value, the quality, the efficiency, and stand above our peers in the care that we provide to cancer care patients. And even let's say maybe let that oncologist compare his quality value to those other physicians in that model to show, look at the great things that we're doing. I just don't think ACO models are going to have open arms to the oncologists for those very reasons. Therefore, the oncologist needs to, and the cancer center needs to create their own value to market.
How do you think, for instance, the 6 standards that were set by the NCQA relate to the patient-centered oncology-based medical home?
I think a lot of those 6 basic fundamentals are constant and remain in any care setting. What's different is the uniqueness of cancer care, the sense of urgency in which patients are seen. There's different measurements. The NCQA and their models are very good about coordination and outreach and patient satisfaction. There's the value component, though, that is missing, and I think that's where a lot of those pieces and parts of the patient-centered medical home that NCQA has done can be brought into the cancer model, but we need to embellish it to add more value to it and actually add more value to the recognition as well. Make the bar a little higher. Oncologists, if we're allowed, could get into the NCQA model with 35% score. That's almost too easy. And if it's too easy, where's the value? And if so many primary care physicians are already doing it, is it really, really that difficult? We want to make it a little bit tough because we want to distinguish higher quality from quality that's not as good, or high value from value that's not as good. Okay.
And how do you think the quality of patient care will fare as these new systems are implemented?
I think if anything, it's going to go up. I think the cancer patient, the families of cancer patients are becoming smarter. Their expectations are higher, and through this effort, we're going to be educating payers, we're going to be educating patients, we're going to be educating families, the community, and seeing we define quality cancer care is utmost. And if we can be in the driver's seat and make that happen, then the patient and the family would embrace it higher. So I think through this effort, we're going to be just emphasizing and measuring the right thing. We may be doing it now, but how well are we doing it? And if we're not communicating or not demonstrating it, then how do we know if we're doing it at all?